Hello, my name is Dr. Gandor. I work in Bielitz-Heilstätten in the Parkinson's Disease Hospital, and I'm going to give you a talk today about cannabinoids in Parkinson's disease. And before we dive into the clinical data on the effect of cannabinoids on PD symptoms, I'd like to take you on a little introductory tour on what cannabinoids are, what the endocannabinoid system is, what receptors we're dealing with before we look at the actual data. So the first slide shows you that cannabis is actually not that one substance that you look for when you talk about the effects of cannabis, but it's actually a mix of more than 60 substances that can interfere with the human body. And the most important ones are cannabidiol, CBD, and tetrahydrocannabinol. And I'm very grateful that we can abbreviate those substances because it's quite hard to pronunciate. So THC and CBD are the two most important cannabinoids that are found in the plant Cannabis sativa, and their chemical structure was identified in the mid-60s by a group from Israel. And it took another 30 years before we actually understood how they interfere with the human body. And we found, and that was done in the mid-90s by a group from Monroe and colleagues, they identified the three-dimensional structure of the cannabinoid receptors, and the two most important ones are the CB1 receptor and the CB2 receptor. And the understanding that the body actually has some receptors for cannabinoids led to the idea that there is an endocannabinoid system in the human body. So we have receptors and we produce cannabinoids ourselves. Here are the two most important ones as an example, that interfere with those two receptors. And opposing to the endocannabinoids, we have phytocannabinoids that are produced by plants. And thanks to the identification of the three-dimensional structure of the CB receptors, we now are able to synthesize synthetic cannabinoids to interfere with those substances and potentially provoking therapeutic effects on numerous symptoms. When we talk about those receptors, they're not equally distributed throughout the body, but we have the two most important receptors, CB1 and CB2. And CB1 is predominantly expressed in the central nervous system and has very high concentration in those structures that are listed here, while CB2 is predominantly expressed in the peripheral nervous system, the gastrointestinal tract, and the lymphatic tissue. And in 2014, it was discovered that they actually also exist a lower concentration of those two, of this receptor in the central nervous system, predominantly in the brain stem and the dorsal vagal nucleus and the ambiguous nucleus and so on. And the identification of the receptor led to the understanding that we don't deal with that one substance that has an agonistic property on that receptor, but we understand that there are substances that have an agonistic effect and some have an antagonistic effect. And since we're talking about G protein coupled receptors, they promote different intracellular signals depending on the ligand that attaches to the extracellular domain of that receptor. And so we can have promoting intracellular properties as well as inhibiting ones depending on the ligand. And already for the two phytocannabinoids, THC and CBD, we understand that while THC has an agonistic property on the CB1 and the CB2 receptor, we see that CBD has a almost opposing effect with an antagonism on the CB1 receptor and a partial agonism on the CB2 receptor. And this agonism on the predominantly in the central nervous system expressed receptor CB1 by THC is probably responsible for the psychotropic properties of cannabis as a whole. And we're not going to dive into detail about every single cannabinoid and its properties, but I'd like to point out this review that was published very recently in 2020 by Arne and colleagues that lists all those cannabinoids and their properties and their action on those CB receptors. The question now is, after that first part, the first introductory tour, if you will, and I've equipped you now with the basic understanding of the endocannabinoid system of THC and CBD and of the potential effects of synthetic cannabinoids. The question now is, why should we as movement disorder specialists in treating Parkinson's disease patients, why should we be interested in this endocannabinoid system? And I give you two very good reasons. One you'll see. And the first one is that there's a very high concentration of cannabinoid receptors in structures of the central nervous system that are relevant to movement disorders and that are involved in the pathophysiology and in the neurodegeneration of movement disorders. And I'm talking caudate nucleus and putamen and the substantia nigra. So they're all important structures involved in movement disorders. The second one is that in 2016, the November issue published as their leading article this review by Blomfield and his group. And this high-ranked published article reviews the effects of THC on the dopamine system. So that also increased the interest of the research population. But within the last 5 years, not only has the legal status of cannabis changed in many countries, also there was an increase in the public awareness of cannabis as a potential treatment option for chronic diseases. And I give you one example. We faced patients coming to our clinic telling us, we've seen on telly that Parkinson's symptoms can be improved, can be alleviated by cannabis. And we asked them, where did you get this information from? What is your information based on? And they told us, we've seen it on Lindenstraße. Now, Lindenstraße is a TV show, very famous German TV show. The equivalent in UK would be Coronation Street, or in France, Plus Belle la Vie, or in Australia, Neighbours. So you'll see it's quite a prominent TV show. And one of the leading characters in this TV show suffers from Parkinson's disease, and as part of that show, he consumes cannabis and has a sudden improvement of his Parkinsonian symptoms. And based on this, patients come to us and say, we also would like to have some cannabis to treat our Parkinson's disease symptoms. Now, the question is, can we recommend, as movement disorder specialists, can we recommend cannabis or cannabinoids for the treatment of Parkinsonian symptoms? And if so, for which symptoms and what substance? And this leads me to the second part. We're going to dive into the clinical data that so far is available on cannabinoids and PD symptoms. And this slide, that's it. We have very few research data on the effect of cannabinoids on PD symptoms. We have a couple of surveys, we have a couple of case series, we have only, and here are only listed 4 randomized controlled trials. A 5th one was published last year in Annals of Neurology that I'm also going to dive into a little bit further down the track. But I'm going to give you a tour through all those little case series and the randomized controlled trials, and then at the end we're going to come to a conclusion whether we should recommend cannabinoids or not, and if so, on what grounds do we base our judgment. The first one is on the 2 surveys that are available. One is from the Czech Republic and one is from the United Kingdom. And what the Czech Republic, Ms. Venderova did, she sent out questionnaires to Parkinson's disease patients. She received 339 back, and 85 of them reported regular cannabis consumption. And then the question was, what symptoms do you feel might improve with the consumption of cannabis? And most of them described, or about 40% described just general improvement of their well-being. About a third expressed an improvement of tremor and rigidity. Some, about roughly 40%, described an improvement of bradykinesia, and less than 20% an improvement in levodopa-induced dyskinesia. Sorry again. So overall, in general, we can say there's a positive signal that cannabis consumption might lead to an improvement of those cardinal symptoms of PD. The other study, the other survey actually, on 411 Parkinson's disease patients showed an overall improvement in motor and non-motor symptoms. They did quite a big test battery here and inquired about motor and non-motor symptoms, and the majority expressed an improvement in PD-associated symptoms. When we now have a look at the case reports, there's 3 case reports that have actually enough quality to be mentioned here. The first one was from 1990, and Frankel and colleagues assessed whether smoking cannabis would improve tremor. And they had patients assessed before and after smoking 1 gram of cannabis, which contained 2.9% THC. And they didn't come across any improvement of that symptom. Another study by Chagas and colleagues from 2014 assessed the effect of CBD in different doses and overall found an improvement of parasomnia. The other non-motor features and motor features didn't change. The last case report from Lotan and colleagues, 22 patients were assessed motor and non-motor battery, and this was assessed before and half an hour after smoking half a gram of cannabis. Again, here we don't know what cannabis, we don't know the concentration of THC or the ratio of THC to CBD. What was the result of this case report? It was reported an improvement of tremor and of bradykinesia. Again, this is all open label case reports. We don't know the exact effect because we don't have a randomized control environment. And this leads me to the next 5 slides, which are about randomized controlled trials. And the first one was published in 2001 by Ziratan and his colleagues, and he assessed, or they assessed whether nabilone, and nabilone is a synthetic receptor agonist on the cannabinoid receptors, whether nabilone would have any influence on levodopa-induced dyskinesia. And they had 7 patients randomized to either placebo or 0.03 milligrams per kilogram nabilone. And half of that dose was given 12 hours before, and the other half 1 hour before an acute levodopa test. And indeed, this work group found a reduction in the severity of levodopa-induced dyskinesia and reduced duration of levodopa-induced dyskinesia. Other motor scores were not significantly different, neither in the off nor the on state. Again, remember, there was an acute levodopa test, so we have off and on data. So here as well, we have a positive signal. We can see that there is a reduction in levodopa-induced dyskinesia with nabilone, a synthetic CB1 and CB2 receptor agonist. The second randomized controlled trial from 2004 by Carroll and colleagues assessed 17 patients, and they applied Cannador in a 2-to-1 ratio. Cannador is 2.5 milligrams of THC and half of that of CBD. And the design was that patients were randomized to either Cannador or placebo for 4 weeks, and then after a 2-week washout phase had a crossover. And so this is already a little more elaborate study design, and a huge test battery was performed with non-motor and motor scores. And after the treatment with Cannador, there was no improvement in any of the scores. Levodopa-induced dyskinesia remained the same, motor symptoms didn't change, the quality of life didn't change, and sleep parameters didn't change either. So a negative study on Cannador, 2.5 milligrams THC and 1.25 milligrams CBD for 4 weeks. The third randomized controlled trial assessed CBD only against placebo. And 21 patients, you remember that name, they published that case report earlier, and now assessed their findings, whether they could replicate their findings in a randomized control design. 21 patients were randomized to either placebo, 75 or 300 milligrams of CBD for 6 weeks. Here as well, there was a test battery of motor and non-motor scores, and while the 300 milligram CBD group, only that group improved in the PDQ-39 overall score, all the other parameters remained unchanged between the groups. So a partially mildly positive signal. When we assess motor scores, we don't see a positive result here. The fourth randomized controlled trial is a very small one. 4 patients were randomized to either receive placebo or rimonabant, 20 milligrams per day. Rimonabant is a synthetic cannabinoid and is a potent CB1 receptor antagonist. What did they find after 16 days? No change in motor scores, no change in levodopa-induced dyskinesia. So again, a negative result. The last trial is from Innsbruck, published very recently in 2020. And I'm going to dive a little bit further into the study design. They assessed patients that were stable with their motor symptoms, but that still experienced non-motor symptoms that were thought to be caused by their Parkinson's disease. And those patients were equipped with nabilone. Again, you remember, is an agonist, and nabilone was given to them, and in 1 to 4 day intervals, they were called up and it was asked, how are you? How are your symptoms? Have you improved? And if they haven't, then the daily dose was increased in 0.25 milligram intervals up to a maximum dose of 2 milligrams per day. Patients were excluded when, with 2 milligrams per day, they did not report a significant improvement of their non-motor symptoms. This was the first phase of the study, an open-label dose-finding phase. After that dose was found that improved significantly the non-motor symptoms, patients were entered into a double-blind placebo-controlled phase and allocated to either and randomized to either nabilone in their found dose or into placebo. And so, not surprisingly, to be honest, they found an improvement of non-motor symptoms, but no improvement of motor symptoms. And when you think about the design again of this trial, in my opinion, you have a huge selection bias because you only have patients that you already know respond to nabilone in the first place enter the randomized control phase. So the huge selection bias, which then lead to this result, which then, of course, is not surprising. So here we are, 5 randomized controlled trials, 3 case reports, 2 surveys as available data on the effects of cannabinoids on Parkinson's disease patients. Would you now recommend cannabinoids to PD patients? What, from my point of view, we can say is that the randomized controlled trials, based on the published data here, did so far not replicate the postulated positive signals drawn from the surveys and case series. So that's the first point. The second point is we have such a heterogeneous application of cannabinoids. We have phytocannabinoids being applied. We have synthetic cannabinoids being applied. We have different doses. We have different forms of application that we still can't draw any final conclusion from those randomized controlled trials or case series or open surveys. The other question, or the other point that we have to bear in mind, are the potential side effects that cannabinoids have. And this is the third part of my talk that I'm going to highlight, is we have a little tour on the side effects. So the first one, of course, are hallucinations. And hallucinations are very prevalent when consuming cannabis. And as I said before, it's probably mostly due to the effects of THC on the central nervous CB1 receptor that is predominantly expressed in the central nervous system. And this is a beautiful study looking at the different forms hallucinations come in and the severity that cannabis can provoke hallucinations. And did we have this effect in the studies that I just mentioned? Yes. The case report on 7 patients, 5 of them reported visual hallucinations. That was nabilone versus placebo. So we have a synthetic CB1, CB2 agonist. The other study by Lotan and colleagues, where patients were asked to smoke half a gram of cannabis, 6 of the initially 28 screened patients discontinued due to visual hallucinations. And interestingly enough, rimonabant that I mentioned in a randomized controlled trial was discontinued in 2008 in Europe because it caused significant visual hallucinations, and there's a significantly higher risk to develop visual hallucinations with rimonabant. Another side effect that we have to bear in mind is orthostatic syncopes or orthostatic hypertension that can be induced by marijuana. And this is a very interesting study that showed before and after consumption of cannabis, the mean arterial pressure and the cerebral perfusion. And they could show the mean arterial pressure dropped significantly and the cerebral perfusion also dropped. And they did that by transcranial Doppler studies. Is that something that translated into our Parkinson's cohort? Yes. All 7 patients in that same nabilone cohort suffered from orthostatic hypertension, and 1 was unable to discontinue the study because of orthostatic syncopes. So again, this is something, and we deal with PD patients that already have blood pressure issues. We know that levodopa itself can induce orthostatic hypertension, and putting on top another substance that has a high prevalence of inducing orthostatic syncopes might then accumulate this problem further. Another side effect, and that's quite an important one, and it was published in Circulation in 2001, is that the ingestion of cannabis can cause myocardial infarction. And you can think a little bit about why. You cause an adrenergic reaction in the body, which is further promoted by the orthostatic hypertension. The body wants to increase the blood pressure again, and this increased adrenergic state will then increase the oxygen demand of the myocardium, which then might lead to a myocardial infarction. And this study in Circulation showed there's actually a time dependence, and about 1 hour after consumption of cannabis, there's an up to 4.8 increment of the risk of developing a myocardial infarction. And the population that we are dealing with is that elderly population that might already have cardiovascular risk factors or even comorbidities. So again, here, I would be very hesitant to apply a substance that we know can cause those side effects. So when we sum up what we found so far is the positive effects that have been found in the surveys on PD symptoms could so far not been replicated in the very few randomized controlled trials that had a very heterogeneous design, very heterogeneous application form of cannabinoids. We see that there might be an effect on levodopa-induced dyskinesia, but it has been inconsistent throughout the studies. One study showed there was a benefit, some studies did not find anything, again bearing in mind the different form of application and the different form of assessment. The third most important point is that if we have postulated beneficial effects of cannabinoids on PD symptoms, we do have to bear in mind those very important side effects that our elderly population, our elderly Parkinson's disease patients are probably more prone to have than patients that are significantly younger and might profit from cannabis consumption, such as multiple sclerosis associated pain or associated spasticity associated pain, where cannabis consumption has shown significant effects. The last important point that I want to make is don't believe everything you see on telly. And with this slide, I'd like to thank you very much and am looking forward to your questions now.